Good morning, everyone. Today I'll be talking about medical management of acute chemical injuries. Ocular chemical injuries are true ophthalmic emergencies that require immediate and intensive intervention to minimize severe complications and profound visual loss. These severe complications occur due to a non-healing corneal epithelial defect in the acute stage, and in worse situations later, corneal scarring, perforation, and later on glaucoma. The presence and extent of epithelial defect is the one effect of chemical injury that determines the severity of the injury, the various sequelae that are to occur, and the severity of inflammation. In other words, inflammation and epithelial defect are mutually inclusive factors that determine the final outcome of a chemical burn. The primary aim of all therapy is to re-epithelialize the ocular surface. The first and foremost important step is the removal of the inciting agent by copious irrigation. The basis of doing so is to normalize the pH to less than 7.4. So the irrigation is done with tap water in the pre-hospital setting, and once the patient reaches the hospital, even before you have seen the patient, or rather than making the patient wait for the optometrist to see, they have to be taken directly to the procedure room, minor procedure room, and the eye has to be irrigated with ringer lactate. And commercially available pH paper is available, and you can check and do the irrigation till the pH is almost till 7. Never neutralize an acid with a base, as it causes more damage. And in Lyme or tuna injury, examination under anesthesia is mandatory in children and in uncooperative adults, because especially to look at the fornices. Some suggest paracentesis and removing an aliquot of aqueous and reformation with buffered phosphate solution can lower the pH by 1.5 units in case of alkali injury. Diphoterin or Prevor, it is a proprietary amphoteric solution, and it has been heralded as a universal emergency irrigant, but which is not available here. So large chunks of tuna like this can be manually removed with forceps, and then the irrigation continued. And pultaceous matter which is stuck adherent to the conjunctiva, this is a cement injury, so these can be loosened first by irrigating with a low strength EDTA solution, and then removed with cotton buds. Now, control of inflammation is vital, and for this topical steroids have to be given, and that is the mainstay of therapy in the first week to 7 days, first week to 10 days following the injury. There is a risk of accelerating a sterile melt by use of topical steroid. However, stopping the steroid can be equally detrimental to the process. So in case you are continuing topical steroid beyond 2 weeks, then it has to be combined with an amniotic membrane grafting. The choice of topical steroid depends on the severity and the strength of the chemical injury. So a stronger steroid like prednisolone acetate or dexamethasone is required, or a weaker steroid like fluorometholone or loteprednol in minor injuries. Intraocular pressure rise can be treated with topical alpha or beta blockers. Oral carbonic anhydrase inhibitors can be given if the patient can tolerate it. In rare cases, a beveled paracentesis may be required for urgent lowering of the IOP. But also assess for steroid responsiveness. Quite a number of patients will turn out to be steroid responders, and this has to be checked on regular follow-ups. Lid position and periodic blinking are usually disturbed temporarily even in the mildest of injuries. So non-preserved tear substitutes are required for symptomatic relief, especially CMC 0.5% or 0.3% HPMC eye drops. A strong mydriatic should be given to relieve ciliary spasm, and prophylactic antibiotic eye drops can be given 4 times per day, or antibiotic ointment at bedtime. For pain management, a simple bandage contact lens can be applied. Pain management is not very complicated because it is very short-lived because of the destruction of pain receptors. Oral NSAIDs can be used, but topical NSAIDs should never be used. Photophobia can be extreme, and it usually requires dark glasses. During the repair process, the fibroblasts invading the cornea are usually immature, and the collagen produced by them is underhydroxylated. And this tissue characteristic is sine qua non of localized tissue scorbutus. So this ascorbate deficiency, it causes a faulty repair process, and it tips the destruction repair ratio towards tissue disappearance, and hence corneal ulceration. So 10% topical ascorbate, if available, can be given, along with 1 gram ascorbate orally per day up to the time of re-epithelialization. And it has been shown that ulceration is diminished by this therapy. Transitional stage begins as early as 1 or 2 weeks in milder injuries and as late as 1 to 2 months in severe cases. And a persistent epithelial defect is usually due to limbal stem cell deficiency, persistent inflammation, and exposure. At this time, drug toxicity is an important cause of PED. Preservatives such as benzalkonium chloride and ointments containing lanolin can perpetuate or create new epithelial defects. So it is wise to avoid topical treatment with multiple medications in hope of preventing corneal ulceration. Cysteine and acetylcysteine are both effective inhibitors of collagenase, and it can be used at this stage. And acetylcysteine is more readily available in the form of mucomist, 10% or 20% solution. It should commence 7 days after the injury. For PEDs, autologous serum eye drops have made a comeback, and it is a method of establishing epithelial integrity by growth and migration. It can be used every 2 to 3 hours initially, reducing to 4 times a day, and only stopping weeks after the defect has disappeared. And failure of epithelialization at this stage means that a stem cell deficiency has ensured. Citrate, as an alternative, it acts as a chelator of extracellular calcium and virtually halts all neutrophilic activities, and it helps corneal ulceration. And it can be given, if available, in the form of topical eye drops. There are some newer alternatives like fibronectin, albumin, and epidermal growth factors, which have shown tremendous response in laboratory studies. So if there is a repeat melt, then a repeat corneal amniotic membrane grafting can be done. Oral doxycycline 100 mg twice daily and then once daily, along with tetracycline ointment 4 times daily, acts as effective collagenase inhibitors and inhibits neutrophil activity. Any perforation at this stage has to be surgically managed. So in summary, no effort should be spared in the management of acute chemical injuries. Primarily, efforts have to be made to restore epithelialization and reducing inflammation, and also to reduce the intraocular pressure. Unaddressed ischemia and exposure has been the cause for non-healing defects and melt. Providing an alternate source of cells in an eye with a severe grade injury is of paramount importance. Finally, a limbal epithelial transplant may be required along with a lamellar or a full thickness corneal graft. So I would like to invite everybody for All India Conference 2024, and the registration is open.